Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with a humongous dead skin plug, and upon first appearance in the ear, it didn't look like a complicated case. They had been using some drops for the last couple of days, and that softened the more lateral wax and dead skin. You can see it's quite mushy here at the entrance. But as soon as I suctioned that softer lateral wax and dead skin, I came in contact with the main plug, and you can see me here trying to lift this plug off the bottom of the ear canal. Now this skin plug was still in part attached to the ear canal wall, so it was having to play tug of war with the ear in order to remove this. And in order to remove a skin plug like this when it's attached to the canal wall, you want to try to detach it from the side canal wall. So initially working from the bottom, just working from the side there. And I believe I'm going to use an ear hook. So what I want to do is almost glide the hook in between the ear canal and the skin plug to separate the plug from the canal wall. But it was such a dense, hard plug of dead skin. It was almost like cement. And I've managed to glide it in the gap. And what I'm now trying to do is rotate the ear hook so the tip embeds into the core, almost trying to hook it out, hence the name of ear hook. That's what it's designed to do. We want to get in behind, turn the hook so the tip embeds into the core of the wax and skin plug and bring it through. But when I embedded the tip of the hook into the core of the skin plug, the core was a lot softer, so the hook just ended up dissecting the skin plug as opposed to removing it. Now I could feel that the skin plug was most adhered to the floor of the ear canal, so I've angled the hook in such a way where the tip is projecting underneath this skin plug, and I'm trying to get it up and away from the floor of the ear canal, and it was quite a tussle there actually. So trying to go to the front part of the ear canal, you can see where I am now. The skin plug is attached to the canal wall anteriorly. And again, I'm just trying to get the tip of the hook into the core, trying to separate it. So at this stage, I'm not really removing much dead skin or wax, but I am separating it from the canal wall, and I am chiseling it into smaller pieces. So again, you can see these smaller pieces, which I can then vacuum away. And once more, I want to go deep into the ear, over the roof. So I've managed to glide it in and behind, but when I then rotate the hook, I'm hoping to get some purchase and some grip, and trying to pull it in one singular piece, but it's not enabling me to do that, and it's just breaking up into smaller fragments. So I'm just micro suctioning some of the smaller fragments. I'm going to go to the floor of the ear canal again. Again, I can feel this is the region where I need to work on, and just sense that once I'm in the ear. So I'm trying to lift it up and away, and you can see how strongly attached this is to the canal wall still. So this skin in most people would naturally die, and when it dies, it's replaced by another layer of skin underneath. So this dead layer of skin is pushed to the surface. It then sheds, and it should migrate. And during the shedding process, the skin cells should almost detach itself from one another. So when the skin is healthy and it's lining the ear canal wall, these singular skin cells are connected to one another. But when they die and shed, they should almost flake off like individual fish scales. It's got that appearance, these squamous epithelial skin cells. But in this patient, you'll see it in the close-up still image at the end of the video. Although the skin has died, it hasn't flaked away, and the skin is still attached. All the individual skin cells are still attached to one another. And you can actually see the layers of dead skin. They're like wafer thin layers of dead skin, and they're still all intact. And it's just another layer of skin upon another layer of skin and upon another layer of dead skin, like an onion almost. And you can see the different the textures of the individual layers of the dead skin. So I've managed to now get the forceps underneath that plug. So where I was working at the base of the ear canal, I lifted it up enough for me to then get the bottom jaw of the forceps underneath the skin plug without grazing the floor of the ear canal, because that would be uncomfortable. And now I've got a good grip, and I'm just tugging away. You can see the skin plug, it came out in a huge piece, but there's still more layers here. But the patient felt immense relief. They were willing me to remove it quicker, actually. So when I've got a skin plug like that, I generally try and do it a bit slowly so it's not uncomfortable for the patient, because as I mentioned, the outermost layer of dead skin in this plug is still partly attached to the canal wall. So when we're separating that, it can be uncomfortable. So I like to normally just do it in small little movements, so nothing quick that can be uncomfortable. But the patient actually wanted me to do it the reverse. I just wanted to get it over and done with. So the last couple of plugs there I removed quite quickly. I'm just going to mop up and peel away some dead skin that's still here. And do watch till the end of the video. You've already seen it in the thumbnail, but you'll see the still image of this skin plug, and you can probably witness there on the canal wall where that skin plug was still attached to the canal, and we're having to separate it. You can see all this with the separation marks. You can see the ends of the dead skin that was still attached to the plug that we removed, and the other remaining section of that dead skin is still in the canal. So it was a real tussle. I'm just using a Jobson horn to mop up around the edge. Now this patient has got quite a bendy ear canal, so in part it may be as a result of their ear anatomy why they're getting this build-up. The skin's just failing to migrate. So this is the same patient, this is their right ear. Again, it's a lot of dead skin, but it was nowhere near as bad as the left side. And it looked a lot looser initially, so I thought I would go in with the microsuction to see if I can vacuum it out. However, I'm going to revert to the forceps once more. And again, I would encourage you to keep watching, because after I remove this initial plug, there's another layer of dead skin that's still attached to the floor of the ear canal, and I managed to get the forceps underneath and peel away that layer of dead skin. It's quite a delicate job to do, because the entrance of this patient's ear is quite narrow, and the forceps are quite, although they're micro forceps, in a narrow ear they can take up a lot of space, and there's little room for manoeuvrability in there. So I'm just going to remove this first. So just change the angle of the forceps. So the bottom jaw's at 3 o'clock, the top jaw's at 9 o'clock, and there's just enough dead skin here for me to grip onto. But remember, it's still attached to the canal wall, so as I'm bringing it forwards, I'm having to wriggle it left and right just to try and separate it. And we've just got it, there's the first bend. So the cartilage you can see, the flesh you can see on the left where the hair's protruding out from, that's the first bend. And just to the right of the plug, that's the second bend. So we're bringing it through in between the first and second bends of the ear canal. And that area of the ear between the first and second bend is called the isthmus. So lovely healthy eardrum. There's a bit of dead skin just like at the top. It's almost folded upon itself, but that's, I'm not too concerned by that. I'm just going to mop up near the entrance, and again they've used some drops just here, and it's softened the more lateral dead skin. So yeah, the region between the first and second bend, it's called it's an isthmus. It's a narrowing. So isthmus is a medical term for narrowing, and it's that's one of the narrowings, and we got another narrowing about 0.5 centimetre away from the eardrum. The ear canal also narrows there, and the bony part, the osseous part. There's just a bit of debris at the base. Now, as I said, you're going to see that dead skin peel in a moment. So as I remove this soft skin from the floor, you'll see the skin layer peels upwards. So I could technically leave it. It's not going to affect the patient's hearing, but this skin, this patient does have to turn on a yearly or 2-yearly basis, I think it is. So we know the skin is not going to come out naturally. So whilst they're here, I just felt, let's just remove it for the patient. Even if it prolongs their next visit, so they don't have to come, they can delay the visit a bit longer, even if it's by a few months. It will just help the patient. So I've just folded the skin over itself so I can get a bit more of a grip. Otherwise the skin is a bit too thin, and the forceps can just cut into it and dissect it. So the skin where I've got a grip with the forceps is kind of folded upon itself to thicken it. So I've got some purchase and I'm peeling away. So I managed to get some skin, but you can see there's a layer of skin still there. Fortunately, it's just off the bottom of the ear canal, which enables me to glide well, I inadvertently pushed it back down, but I'm going to use the tip of the bottom jaw just to go underneath, and I want to be careful. I don't want to make contact with the floor of the ear canal. As we're approaching the bony part, this is the bony part of the ear now, so the flesh to the right, that's the second bend. Beyond the second bend is the bony part of the ear canal. And you can see I'm just peeling it away. We're not going to get every little aspect, but I'm really happy that there's quite a sizable piece of dead skin that I removed there. So I'm just going to peel away some skin from the anterior canal wall. And the patient did experience some of the caloric effects. So sometimes when you suction in the ear, it reduces the ear temperature, and each ear has got an organ of balance, and they can be affected by temperature and pressure. So the patient felt slightly dizzy, so we just left that last remaining piece of skin. So these are the close-ups. So there's 2 close-ups, and you can see those layers. They're like wafers, and they're all stacked upon each other. And the outermost layer, so the one at the floor, that's the fresher layer of skin. And as you go in, you can see that the colour does somewhat get darker. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.